semester. So in the concept of infection, we discussed all about the um, cycle of infection and the reservoirs, primary, secondary, the host, what type of infections, and a little bit about the microbiology, anatomy. We went into that, and now is the time that we are going to get into the details of the disorders related to infection. Right now is the really like when you're going to learn about this diseases you'll see in the hospital, how to best take care of the patients with those disorders. When you have a baseline knowledge about the pathophysiology, signs, symptoms, treatment, your role, you'll be better able to manage that issue. And so just to give you a background so that you have a clear understanding what we're going to talk about in next 2 hours, is that we are going to cover 5 diseases, and I hope you got a chance to go to through the PowerPoint and through the readings that were posted in the pre-class activities, just so that you have some basic idea. But we will talk about it now. And so there's 5 disorders that we will cover. 3 are bacterial infections, which you can see on this title slide. It's cellulitis, otitis media, and chlamydia. These 3 infections, and I have a second PowerPoint, which is relatively a shorter PowerPoint that has 2 more infections, which is Lyme and candidiasis. Lyme is again a bacterial infection, but it is considered as a vector borne because it really needs a vector to infect the human being. And candidiasis is a fungal infection. That's why I kind of created a separate PowerPoint so that you can clearly identify, okay, these 3 are solely bacterial infections, right? So this is a little bit about that. And now about the readings that you're going to do, how you're going to study for this topic. Cellulitis and otitis media. These 2 are very well explained in your textbook. It is chapter 9, I think, I believe. Chapter 9. And there is 2 exemplars that is titled as cellulitis and otitis media. So we will talk about it. You obviously are going to refer to the PowerPoint and our discussion that we're going to do, but you're going to through the book nicely because it has some care plans, it has case studies that you're going to go through, and also the content itself. Now, respiratory disorders is a different story. You don't have much information in the book. It's a chlamydia, candidiasis, and Lyme disorder. I have put the page numbers. It's probably like, 1 page reading, half a page reading in the book that you can find. But in the PowerPoint, you will get a lot more information about these 3 diseases, and also our discussion that we're gonna do. You will have a better understanding with that. If still something is not clicking in, you can always afterwards reach out to me because there is not much information in the book, and I recognize that. So you can always reach out to me. You need a little extra time, you email me. The other side, there is plethora of like literature review or the articles that you can find if you start Googling something. I think CDC I have found is a good website that has basic understanding in a layman language, pretty much. About these 3 disorders. So if you need a little more information, which is literature supported, you can go on the CDC website. So this is about the volume 1 book, that the Pearson volume 1. All the information is there. The second part of it is pharmacology. I have posted the readings in the pharmacology course in Blackboard for that part. So basically, you are going to go to the module 35, and there is like 4 pages of reading on the antibiotics. Antibiotics, we are going to cover 4 classes of antibiotics, and there is some information in PowerPoint, but you're going to go through the reading as well. It's penicillin, macrolide, tetracyclines, and cephalosporins. So these are the 4 classes that you're going to go through nicely, right? And these are pretty much interchangeably used for these infections. One works for one patient, they get resistant, and we, try the other one. It's pretty much like that. And the classes are basically, these are classified based on their mechanism of action. Some of the classes work on the cell wall, some work on the RNA, and also based on the type of microorganism it targets. And for example, gram-positive, gram-negative. And but there is a pharmacology content as well from chapter 35 of your pharmacology for nurses book, and chapter 36 has a little bit about the antifungal medications. And again, all these readings are listed in the pharmacology content, because as you know, there is no separate pharmacology course for you, so it's all embedded in the disorders that we discussed. So before we get into the infection, I want to share a very quick, right in the beginning, I want to share a very quick 2-minute video with you, because I want you to recognize the importance of our discussion today. All these bacterial infections or any type of infection, what is the one most extreme complication that can happen with all these infections? Can anybody tell me, what do you think? The extreme part now, okay, we are here and we really need to manage the patient. There you go. Yeah, resistance can be one, but sepsis, really, sepsis, right? Septic shock, one word that comes to our mind right away with any type of infection is septic shock, right? So this quick 2-minute video will give you a good idea of like how important it is for you guys in next 2 hours to pay attention to what we are talking about, right? So that you're better able to manage the patient when you are in the clinical rotation, and also when you are working as RN. So let me just share my screen. And you can let me know if you are able to hear well. It's a quick.
A Cedar Park woman as a warning for moms like her. What she thought was the flu instead landed her in the.
I stopped it. I just want to make sure you guys are able to hear it well. Oh, perfect. Just wanted to make sure. So I'm going to replay that, okay?
Emergency room, fighting to survive.
The young mom of 2 was in septic shock, and she says it left permanent damage. So she shares her story with KXAN's Amanda Brandeis. So you know what to watch out for.
Certainly,
It's cutting off, Professor.
It was just something in me.
It's cutting off. It's breaking up real bad. Okay. All right. I don't want to.
Someone said if you mute your microphone that we might be able to hear that better.
Okay.
Okay, yeah, no, that didn't work.
We're not getting volume on it.
Okay, I was muted. I am here. I am here. Believe me. Yeah. And okay, so let me explain it to you guys. So there was a story about a mom who had 2 little kids, and she had UTI and very like mild symptoms of UTI. Totally did not pay attention to it. Didn't think she needed antibiotics, and she ended up with a septic shock, had to go to the emergency, and competent nurses and competent doctors there, they were able to recognize the signs and symptoms, which I will tell you how to recognize that. And acted right away, right? And what they're gonna do is that they are gonna give vasopressors to increase the heart rate. Probably heart rate was going down, blood pressure was going down, or heart rate was high, blood pressure was going down. Managing the temperature, giving fluids, and giving antibiotics right away. She still lost both of the lower limbs, and she lost all of her fingers. Why? Because the blood supply was now cut down, right? That was the extreme that happened just because of not recognizing the signs, symptoms of infection, and not recognizing that it was so important to manage that, right? So that was really a 2-minute story of, I will share the link afterwards. You can watch it at your own time, but that was really a one story out of so many that we have. There is an organization, sepsis.org, so easy to remember. You can also go on their website, and there is numerous stories about septic shock and sepsis and how it was sometimes managed well, how it was not managed well, and people lost their lives. Once patient is in septic shock, is 40%, pretty much 40% chances of survival after that. So you can see how critical it is to manage the infection well. All of these infections can lead to sepsis or septic shock. So let's get started with our first discussion, which is cellulitis. What is some words that come to your mind when you think of the word cellulitis?
Inflammation.
Inflammation. What else?
Inflammation of the cells.
Infection of the cells, redness, swelling, warmth, right? These are like basic words that come to your mind. And when you see any patient's legs swollen or in this position, you will know that it's kind of like heading towards cellulitis, already is cellulitis. But we are going to talk a little bit more detail than that, right? That we know. So first, talking about the etiology, why cellulitis happens. What is the organism that's responsible for that? So here I wrote it as Staph aureus and a streptococcus. This is the staphylococcus, and this is the streptococcus bacteria, right? Coccus or cocci, that means basically a spherical shape, or pretty much roughly spherical shape. You can imagine these are like kind of circular, and Streptococcus is in one chain. You probably remember it from microbiology class. Now this is like linear presentation, and these are in kind of clusters. These are clusters. So this is staph, this is strep. Both of these organisms can cause cellulitis. These organisms, how do we get that? This is a part of our normal skin flora. They live on the skin, right? But they do not cause any infection. Anytime there is low immunity, there is breakdown in the skin, somehow they get entry into the bloodstream. Some people are able to fight it and would never know that the staph or streptococcus, they got entry into our skin layer, which is the first protective barrier, right? The major part of our immune system. And but then after, if the immunity is low, and if the infection is high number of microorganisms, then they're not able to fight that organism, and they get entry into the soft tissues, they get entry into the subcutaneous fat, and some people, they get entry into the bloodstream, and that's how people go to the septic shock. Then this is a little bit about the pathophysiology. This is erysipelas. This is one term that we use to signify for this redness that we see on our patients. This redness or erysipelas, this is caused by streptococcus, specifically group A streptococcus, and it affects mostly the lower extremities and the face. And again, as we discussed prior, that these are bright red spots on the lower extremities, and these have a very well-defined borders. And when we have cellulitis, then we usually, you have seen that practice that providers, they mark the area with the permanent marker, and we assess if it is going out of those borders, but usually it's very well-defined borders. And the prognosis is good if treated promptly, but we have seen in our experience that many times, if it's left untreated or the antibiotic is resistant and it is not working properly, then sepsis happen. Risk factors for cellulitis now. In children, there is risk factors are trauma, impetigo. What is impetigo? Anybody knows? Probably all have seen that, just the terminology. Fainting, no. It's maybe you have seen it. Yeah, it's a little ulcers that you have seen on the face. Yes, that's right. Yeah, around the mouth. Yes, that's right. Those dry spots that sometimes you see around the mouth, and especially in kids. Adults can get it too, especially in kids. That is again a bacterial infection, probably caused by staph or streptococcus. So if they have that, they are at high chances of cellulitis, because those bacteria can again get entry into the subcutaneous fat. Yeah, and some adults can get it too, absolutely. And folliculitis. What is folliculitis?
Ingrown
Folliculitis,
hair.
basically ingrown hair. There you go. And follicles are, follicles are little, holes you can say, which are obviously not the big holes that we can say, little holes from which the hair grows out. And if there is an infection of that follicle, that's called folliculitis. Again, you can imagine some of these risk factors are so easy to remember. Why? Because you can imagine that is a bacteria right there, and that can get entry into the dermis, into the subcutaneous fat, and it will cause infection, obviously. And untreated tooth decay, same phenomena. Otitis media, this we will talk in detail. Otitis media, this is ear infection. Older adults are, again, the risk factors are prominent. Impetigo is the bacterial, the ulcers, the dry ulcers and dry sores that sometimes you see around the mouth or face in the kids, but adults can get it too. And those are caused by bacterial infection. And that is one of the risk factors. Is a type of yes, this is a type of cellulitis too. And again, when we are done, like pretty much with 10 slides or so, I have a slide that is specifically for questions. So any questions I can also take when we get done with this cellulitis. Older adults, the risk factors are thin elastic skin, peripheral neuropathy, which can be caused by diabetes, but even people who don't have diabetes and have some CNS issues, some issue with the nervous system, they can have peripheral neuropathy as well, and decreased activity. These are the risk factors. Some other risk factors which are involved are diabetes, again, will cause neuropathy. People won't be able to feel any pain, right? If they have a bacterial infection, that will grow more. So this is a basic phenomena why they're at risk. Obesity, previous cellulitis, PVD, the blood supply is low. Tinea pedis is the fungal infection in the foot, and weak immune system. So pretty self-explanatory risk factors for getting cellulitis. Moving on to the clinical manifestations of cellulitis. So the very first thing that you mentioned, that it's redness, swollen, warmth around the area. These are going to be the major symptoms that you will see in the patients. It can either be on the upper extremities, it can either be on the face, it can even be on the back, but mostly what we see is in the lower extremities, just because of the lack of probably sometimes cleanliness, and in older patients or patients with the say diabetes, peripheral neuropathy, and but it really can be anywhere, right? It just needs that epidermis, the subcutaneous fat, the dermis, and it just gets into the soft tissue infection. So it can happen anywhere, and it's very rapidly growing. And these things again are pretty much moving towards sepsis, fever, chills, or like systemic infection, malaise, lymphadenopathy, right? The lymph nodes, the swelling of the lymph nodes, right? And lymphangitis. What is lymphangitis? Anyone knows what's lymphangitis?
I'm guessing it's inflammation of the lymph.
Yeah, inflammation of the lymph vessels, right? Perfect. Yeah, and you're getting that, right? Itis, again, itis and lymph, something has to do with the lymph, right? So lymphatic system, in all these infections that we are going to discuss, or we are discussing, the lymphatic system plays a major role along with the circulatory system. When you can imagine if patient has a soft tissue infection just on the skin, how is it going to go and spread to the whole body, right? It needs a medium. So near the skin, there is a rich network of capillaries. Those capillaries will absorb those microorganisms. Along with that, there is lymphatic system, lymph vessels, right? Those will also absorb some of the pathogens. It also has the WBCs in there, and that itself, that makes lymph, and it circulates throughout the body. Some of the infection gets cleared by the lymph nodes that has macrophages and dendritic cells. Some of the infection, the body is just not able to clear out, right? And so you should have a very basic understanding of anatomy, physiology. We did discuss it last semester in immunity and infection, that how the microorganisms are going to get carried from the skin to the systemic route. What is one difference between circulatory system and lymphatic system? One major difference, like throughout the body in the circulation. Blood, okay, right? No pump. There you go. Yes, yeah, these all are right actually. And but one major thing that comes to our mind is that, okay, the blood vessels, they carry in the circulatory system. One is a filter, yes, and in the circulatory system, there is blood, and in the lymphatic system, there is lymph. The circulatory system is a two-way system, right? From the heart, the blood vessels are going, and from the body, it's coming back to the heart. Lymphatic system is not a two-way system. So here is infection on the skin, and it has pathogens, right? It has capillaries, and the lymphatic system just ends here. It's not a two-way system. It just absorbs all the pathogens from here. It has WBC in it, and it circulates throughout the body, and there is lymph nodes here, right? And so forth. So it plays a major role in all of the infections. Then after that, here I wrote, you have to be competent again in the, as we discussed in the diversity part, that in darker skin tones, it can be a bit difficult to recognize cellulitis, right? So we have to make sure that we are doing a good observation, and then we are doing diagnostic tests. If there is any doubt, and we have to move towards more rigorous diagnostic tests to make sure it's cellulitis, it needs antibiotics. And we will discuss the diagnosis part as well now. Prevention of recurrent cellulitis. And many patients, they will come to the hospital again and again with this issue of cellulitis because of the weakened immune system, because of lack of self-care, because of comorbidities. A lot of things play a role into the recurrent cellulitis, but again, puts them at a very, very high risk for getting sepsis. And very self-explanatory 5 things that I listed here for prevention is you avoid any type of trauma, keep the skin clean, blood test not from the affected extremity, fungal infections should be treated. These are just some of the preventive measures. And but for example, otitis media is a risk factor, right? Children who are getting frequent otitis media, the prevention would be really to treat the ear infection well. If they need some surgery for that, which we will discuss, we will move towards the surgery to prevent any recurrent cellulitis. Diagnosis, how would we diagnose the cellulitis? First test is a very simple test, which is CBC, and I'm sure you all are really good with that now, that in CBC, we are going to check the WBC. What is the normal WBC count? Probably you meant to write 4 to 11, yeah. 4.5 to 10,000, yeah, and 4.5 to 11. So that's pretty much the range, right? Anytime it's more than 10, more than 11, then we are going to start thinking about whether there is an infection. We will do more extensive tests than that. It's it's a 3 to 10, 4 to 10, 4 to 11. Every organization has different, but it is in that range pretty much. And then more extensive testing if we have to do. Take obviously fluid from that cellulitis area, right, with a syringe. The provider will take it, and we can also do swab culture. If there is some drainage, we clean the wound, we take a little swab and we send it to the lab. That we can do, that is within our practice. But if with invasive procedure, they have to take the fluid, that the provider will do. The blood cultures we can do. Blood cultures, it says on affected leg. Last slide. Sorry, what was the question? I didn't get the question. On slide 3, what does it say? You can unmute yourself. I know one of you had question. Oh, in prevention. Okay. Avoid having blood test taken from, that is really to say, okay, good question. That is really to say that if there is cellulitis in the, say, upper extremity in the arm, and right arm has cellulitis, avoid taking blood samples from that. Say we have to do CBC, we have to do the blood chemistry, the electrolytes, just that regular blood work. Avoid sticking or poking that arm, that is to say that. But if we have to take fluid culture specifically to see the bacteria in there, then we will take from that extremity. Okay, hope that answered the question. But that avoid taking test is like the general test that we have to perform. Okay.
Are you
and
saying that because you don't want the infection to enter the blood, which is why you wouldn't pierce the skin on the infected leg?
Absolutely. And anyways, think about it. If arm is swollen, and just forget about cellulitis, right? One of my arm is very swollen and just swollen, say not even red, right? I would just avoid that extremity to take regular blood samples. Say patient came with COPD and or pneumonia, and every morning all the patients get CBC and blood chemistry at least. So we are going to avoid using that extremity that has any type of issue. Similarly, like think about it as a, patients having a PICC line, patients having any issues with the extremity. So we would avoid taking blood sample from the affected arm. So if patient has cellulitis in the right arm, and I just have to take CBC and blood chemistry, we are going to avoid it. Fluid culture, we have to take from that extremity because the bacteria probably is not systemically still circulating. It's right there on the skin. Does that make sense? Yes, it is still colonized, still there. Yes. But I'm just saying that if it is affected, avoid taking regular blood work from that. Just find a vessel or find a vein in the other arm or some other spots, right? And so blood lactic acid. What is the lactic acid? Maybe have studied about it, and it is a very crucial, very critical blood work that we all should be aware of.
It's a byproduct of the bacteria, right?
In sepsis, yes, it is. In sepsis, the level will be high, right? Basically, it is formed by the muscles. Anytime the muscles is in shock, less than 2.2 is good. Anytime muscle is in shock and there is not enough oxygen in the body or at that tissue, then the lactic acid will be high, right? So lactic acid is one determining factor for sepsis, right? So just to help you visualize how a patient will look when they have sepsis is their heart rate will be high, their blood pressure will be low, their temperature will be high, their mentation would be poor, the lactic acid will be high. So this is really the one picture that comes to our mind clinically when we see patient with sepsis. And now there are, because of the percentage of people that we are getting with sepsis, and there is a lot of various checks, and the computer helps us with that to recognize sepsis. So anytime for our patient, if I am putting all these vital signs and all these determining factors, the computer will start giving me warning that check patient for the sepsis. And patient might have sepsis based on the values that you're putting in for the vitals, for the lab work, for other things. And also there is a device now that I saw once is a sniffing device, and that device is pretty much used in the critical areas in ICU, progressive care units that I have seen. So that device is connected along with all the other monitors, and it has alarms in it. And when it sees all the increased and not WBCs. Mostly the WBCs will be increased when the lactic acid is high. And but having said that, even if there is no infection and there is just lack of oxygen in the body, lack of oxygen to the muscle, lactic acid can be high, right? So it can be present. So if the lactic acid is high, we really have to see the whole clinical picture. Cellulitis is not going to be the only thing. Maybe patient has pneumonia, right? Patient has just some other type of infection, and that's causing the lactic acid to be high. But in absence of the WBC, absence of infection, lactic acid can be high as well. Just to give you a perfect example, one of my patient was when, like, you know, your role is so critical. One of my patient came with COPD exacerbation. So patient had COPD. Many a times he used to come to the hospital with the exacerbation, and they gave steroid in the ER and some nebulization treatment, stabilized him kinda, and they transferred the patient to me. And now it was a new admission for me. And when I took the report and went to the computer, the chart, and it sounded like, you know, pretty simple thing to manage. And but when patient came to the floor, the temperature was high, the blood pressure is low, and the typical symptoms, the heart rate is high. So in the end, we found the patient was in septic shock. Patient had sepsis, right? Pretty much going into the septic shock. So I had to call rapid response right away as soon as the patient came to the floor. Why? Because instead of the COPD, patient had pneumonia. And no antibiotic was given in the ER, no fluids were given in the ER, and although patient's temperature was high in the ER as well. So that's really when, you know, your knowledge and of your good assessment skills come into play, that you are able to recognize that sepsis and you're able to respond quickly, because every minute counts when patient is going into septic shock. And complications that can happen because of the septic shock is ties to the first thing I told you, because of the cellulitis, the complication of cellulitis. So first thing is septic shock, I told you. That's going to be with any type of infection, the extreme that can happen. The other ones are necrotizing fasciitis. So fascia is really like the subcutaneous, and that can get necrosed because of the lack of blood supply. And the purpura is like the purple coloration, ulceration, necrosis can happen. Gas gangrene. So gas gangrene is pretty much like a regular gangrene. And okay, can you hear me well now? I know there was a little issue. And gas gangrene is a little different than a regular gangrene, because now there are air cells that can be found in the soft tissues. There are air cells that are found in the bones. Some of the bones are hollow. They are formed of the air cells. So gas gangrene, basically those air cells, those get infected and the blood supply is impeded in those air cells. And that's how gas gangrene happened. But basically it's a lack of the blood supply and totally dead tissue. Necrotizing fasciitis also is a lack of blood supply and totally dead tissue. What is one word or the color that comes to your mind when you think of necrosis? Black. There you go, black, right? And yeah, red is really the infection part. When it is completely black, you must think that this is now necrosis, right? And that means really we are moving towards the amputation. The story of the mom that I told you, and probably she lost all the blood supply there. There was black, there was no blood supply, and she got both of the limbs amputated. Severe sepsis, it is sometimes called blood poisoning. It's really not a correct word. I put it there if you hear it, but people stopped pretty much using this word, and we are using sepsis now. Infection of the other organs and endocarditis. What are the three layers of the heart? The names of it. epicardium, pericardium, myo, endo, epi. Yes, there you go. Perfect. Thank you. So endocardium is the last layer of the heart, right? And you know that their infection in the last layer there, it can be very dangerous. It can spread to the valves, and we will need valve replacement and things like that. And so cellulitis can also result in endocarditis. Then we'll talk about the treatment of the cellulitis. So as you can imagine that we need some type of antibiotic. You will see and you'll experience when you are in the hospital, it's really sometimes hit and trial because one antibiotic that works for one patient does not work for other. But the general rule is that for cellulitis, usually the penicillin and the cephalosporins, it works well. Penicillin and cephalosporin. Penicillin, usually amoxicillin or something, it's listed on the slide and in your book as well. And cephalosporin has 5 generations of antibiotics that we will discuss. Some generations work depending on the patient. And so, but you must remember that usually penicillin and cephalosporins work good for the patient with cellulitis. And when patients are admitted, they are on IV therapy for 3 to 5 days, and then they are switched to the oral antibiotics of the same kind that's working for them. And all the antibiotics that are available in IV form, they are also available in oral form, or there is some alternative to that, which basically works on the same mechanism. So we want to stick to that. And you all know, and all again, I'm stressing this point, cannot stress this enough, that the patients have to complete the whole course of antibiotic, because the antibiotic resistance is pretty much becoming an epidemic now globally, more in developing nations than developed nations. So here really you would think that we probably don't need to do a good patient teaching when they are on antibiotics. We do, especially when they are nearing discharge, because in the hospital we are taking care of that. They are completing it. When they go home, people have tendency of taking it for one day and they are feeling better, they stop taking it. That's how we are creating resistance to the antibiotic. Penicillin was such a good type of antibiotic, always used to work, it's a very selective, because it just works on the cell wall of the bacteria and not the cell wall of the human body, not on the cells of the human body. So we're very good, are selective, but a lot of resistance is happening to these antibiotics. So really our role comes into play, that we have to do a good patient education. Systemic antibiotics are given, analgesics can given based on the pain. Recovery usually happens in 2 days or so, pretty much like after 2 doses of IV antibiotic, we start to see the results. Should continue at least 10 days. It depends on the type of antibiotic. And penicillin. So here is a little information about, I told you are going to cover 4 classes of antibiotics, penicillin, cephalosporin. These are 2 that I have listed here, and you're going to go through the book for the reading as well. So here's the mechanism of action that I told you, that they work on the cell wall and they work on the absorption of the water. And the primary uses of the penicillin and some of the adverse effect. The main adverse effect that are very easy to remember is that all the antibiotics, they are very harsh on the stomach. So we have to make sure that we educate the patient to take some type of probiotic, yogurt along with that, because they can cause heartburns, they can cause diarrhea. So these are pretty universal. C. diff can happen, right? Maybe you have heard of C. diff. Does anybody know why C. diff happens if patients are on antibiotics or long-term antibiotics, I should say? What is the phenomena behind it? Resistant, disrupt flora. Yes, disrupt flora. And so all the normal flora of the belly, of the stomach, it disrupts it, right? And now there is more chances of infection in the stomach because the protective flora is not there. The antibiotics killed it. It was basically our protective layer. And now it's already not there. And this is little about cephalosporin. And cephalosporin, as I was mentioning, there is 5 generations of cephalosporin, and I have listed the major drugs there. And the generations basically are classified based on the type of bacteria they target. The first generation, they were good for gram-positive, and the second, third are basically for gram-negative. The fourth and fifth we use in case there is a resistance. They are, pretty much broad-spectrum antibiotics, but the classification is based on the type of bacteria, as I have listed here. Some of the nursing interventions would be you monitor for allergy, and you again educate the patient on use of antibiotics, and you monitor for the side effects if the patient is getting any, and monitor for the super infection, just a regular nursing intervention that we do for all type of antibiotics. And lifespan consideration is that in children, there is more chances of getting the cellulitis spread to the systemic route as well, because they have if they have wounds or something, they pick on it, right? And so as we can imagine, it can go to the systemic route. Facial cellulitis can cause meningitis because it's right near the meninges and the brain, right? And older people, they have poor circulatory system, the skin integrity is not there, so they're at more chances of getting cellulitis. If they get it, they're at more chances of the systemic infection as well. And the assessment. So the assessment, I just want to make sure that you recognize that assessment has 3 parts, any type of assessment. Patient interview, which is also called review of system, observation and physical examination, and diagnostic test. And for cellulitis, these are some of the patient interview, which is pretty self-explanatory. Did you get any type of infection before? Did you have any trauma and any skin wounds that you're aware of? And all the risk factors that we listed, we are going to inquire about that. The observation and physical examination is listed here. We are going to check the wound itself. That is going to be our focused assessment. And then we are going to perform the head-to-toe assessment. For example, if we want to see it spread to the lungs, we are going to do a quick, a good detailed lung assessment. And these are the diagnostic tests. So 3 parts of the nursing assessment, which is very important. Implementation would be to give the antibiotics. We can also give warm compress for 4 times a day, elevation of the extremity, and compliance with the treatment. Okay, any questions from this slides that you have? Otherwise, we are going to move to the otitis media. And after otitis media, then we'll take a quick break. Okay. And also in the end, we'll spare time as well if you have questions. So moving to otitis media, your book has a good information about that as well. This is basically ear infection. Media is the middle ear infection, which is most common, but really infection can happen in any of the 3 parts of the ear. This is here I have a good picture so that you have a good idea. This is the external ear, right? And any infection here, it's also called the swimmer's ear, which is listed here. This is the middle ear. This is the eardrum, right? Eardrum, tympanic membrane that we say, shiny white tympanic membrane. These are the 3 bones, malleolus, incus, and stapes. And this is the middle ear. So this is what we are talking about, otitis media. And this is the internal ear. This is the otitis interna, labyrinthitis also it's called, right? But that's not our topic of discussion, at least for now. Our topic of discussion is otitis media, because this is most common. And this here is the eustachian tube, which basically maintains the balance and prevents dizziness and vertigo and stuff like that. And otitis media is most common in children. Clear annotation, okay. And there is 3 types of otitis media. So this you need to remember, and you need to recognize the differences between them, and because the treatment is different in all these. So the first is serous otitis media. In serous otitis media, what happens is it is basically, term can be confusing. It is really not otitis because it's a really just the presence of fluid in the middle ear. Okay, I'm gonna go back to the previous slide so that you have a good understanding. So what happens is that this is the eustachian tube, right? And somehow because this is connected to the nasopharynx here. This is the nasopharynx, and this is our face, and this is like our nose here. Such a bad drawing I'm doing, but just to give you idea. This is nasopharynx or pharynx, and fluid collects in this eustachian tube, right? And it starts to come here as well. And some of the fluid, because of the negative pressure, some of the fluid gets sucked from the capillaries. Everything in the body has a good blood supply, right? By means of the network of capillaries in the end. So the capillaries, so the ear starts to suck some blood or the fluid or serum out of those capillaries as well. And the fluid starts collecting here. But be mindful that this is not infection yet, okay? This is, there is no bacteria there. It's just clear fluid, I want to say. So this is otitis media with effusion, we call it. And the other name is a serous otitis media. But what do you think? Do the patient need antibiotic if they have serous otitis media or otitis media with effusion? Patient does not need antibiotics. Okay, very good. And so because there is no bacteria yet, but if it stays there, if can be allergy, no, yeah, absolutely, Sandy. So because of the allergic rhinitis, right, that also is a risk factor, I want to say, to that. Yeah, and we will discuss the risk factors later as well. The second is the acute otitis media. So this is what we see in kids very, very commonly, that they would have runny nose at first, they would have little cough here and there, and then they start complaining of the ear infection. Usually the runny nose and stuff like that, they precede the ear infection. So in acute otitis media, what happens? Oh, here I wrote it. Typically follows URI. URI is upper respiratory infection. If any of the short forms when you are reading your PowerPoint is not making sense, just reach out to me. Okay, sometimes I don't put the full form there, but by this point you should all know what URI is. It's upper respiratory infection. And going back to that slide, that now instead of just the serum, now it's the entry of bacteria has happened through the eustachian tube, and also sometimes swimmer's ear can precede the otitis media. Patient they are swimming, they're in the water, or somehow the skin gets inflamed, and now the bacteria got entry through the eardrum into the middle ear. And also, I just want to make sure that you guys understand, sometimes you hear in the hospital, especially if you are on ENT floor. I did work on ENT floor for a year or so. And so what happens is that you'll hear the term that tympanic membrane is perforated. And you would think like it's an emergency or perforation has happened, patient might need surgery. No, normally the 90% perforations, they get cleared by itself. They get healed by itself. It's our body is a beautiful thing, right? Body, it just all the resources that are available in body, it gets transferred or transported to the place where it's needed. So it really tries its best to heal the infection, to heal any type of these perforations by itself, right? So that is why it is so important for you guys even, right? I know we are talking here about patients, but even for you guys, your family, friends, to be in good health, right? And again, I strongly believe there is a strong connection between our mental health and our physical health. If we are always under stress and not happy, and all those emotions, they decrease your immunity. And again, it's not like just I strongly believe that. There is literature supporting it, right? And so we have to be in good health as much as possible, right, to the best of our capability, like exercising and good food. And why? In case there is any infection or in case there is any issue in the body, at least our body itself can try its best to heal that infection, right? So these perforation gets cleared, but if it is extreme, then we might need eardrum repair, tympanoplasty, that we will talk in a little bit. And chronic otitis media. So this, as the name itself is signifying, that patient is getting infection again and again now, and now it has gotten to the point where the tympanic membrane is all messed up and kind of destroyed, that we have to make a do tympanoplasty or surgery, and the hearing loss has happened, conductive hearing loss has happened. There is no going again back to, so that you have some idea. So the sound comes from here, from the external ear, and passes through the eardrum, goes into malleolus, then incus, then stapes, and then this is the cochlea. This is where our vestibular nerves are, the cochlear nerves are, and this is the sensory neural mechanism of hearing, right? And these are semicircular canal. And this is the sensory neural. But in the otitis media, what type of hearing loss we will see? We will see a conductive hearing loss, because now there is fluid here. In this part, there is fluid. Now there is no conduction of the sound waves to the cochlea. This is the cochlea right here. And so chronic is that. And then there is this term, which is cholesteatoma. This is decreases vibration, absolutely. And cholesteatoma, what happens in that is that there is, oh my God, I'm so sorry, just give me one. Hi guys, I'm so sorry. My little one somehow opened the door and he started knocking on the door. Yes, I am back. And so cholesteatoma. So we were talking about that. So what happens is that I'm gonna go back again to the previous slide. So here, let me clear the annotations here. So what happens is this is a squamous epithelium here. Squamous epithelium. It starts to desquamate and it starts to go into the middle ear, and there is some growth of the skin here. So cholesteatoma is really it's listed in your book as well. So it is a really growth of the skin that happens in the middle ear. The cells of the external ear, it starts to desquamate, it starts to shed, and that shedding goes into the middle ear, and there it starts a skin growth. And what they do is really a simple surgery, that they lift this eardrum, right? They lift it from here, and there is a delicate surgery, and that they remove the cholesteatoma. So these are basically three types of otitis media that we can see in the patients. Etiology is the causes. So the causes is these three bacteria. Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhales. These two are really the common ones. And as you can imagine, in children, if they are vaccinated against the pneumonia, they are vaccinated against the flu, and the Hib vaccine, HIB. I have listed it later. Hib vaccine, this is a vaccine which is good against Haemophilus influenza. So if they are fully vaccinated with these, this is a good preventive mechanism for against ear infection, okay? And the causes, again, we talked about it, that pus is formed and bacteria, tympanic membrane rupture, and the complication can be that it can cause meningitis or mastoiditis. Mastoid process is behind the ear, again, is a hollow bone made of the ear cells. The bacteria gets entry to the ear cells and can cause mastoiditis, and then it can go to the meninges of the brain, meningitis, and cause conductive hearing loss and barotitis media. This is the airplane ear, where the equilibrium between the outer air from the mouth that is going into the eustachian tube and the air that is going from the external ear to the eustachian tube. That's how the equilibrium is maintained. That is disrupted. That is a barotitis media. These are the complications that can happen. Okay, and infants are more prone because what happens is in adults, the eustachian tube is like that. Okay, make sure you are paying attention to this. So it is like that, and in kids, eustachian tube is pretty much like flat, not completely flat, but pretty much flat. And now the bacteria, it gets clear in adults, but in infants or children, it stays here by mechanism of gravity. So that is the reason, one of the reasons why infants or children are more at risk for ear infection, okay? And then these are the very self-explanatory risk factors that I have listed, and pacifier use, age, and they are going to daycare. Down syndrome and cleft lip and palate is also seen as a risk factor because of the anatomy or something. And preventive measures are these things that I have listed, very self-explanatory and easy to follow. Manifestations of serous otitis media are gonna be, as you can imagine now, that you have a clear understanding of what serous otitis media is and acute. So these are going to be pretty much the symptoms of infection now, right? Temperature and WBCs are going to be high, the pain, and plus it will be there, mastoiditis. So because of that, tenderness will be there, and the tympanic membrane will be red because of the infection, and purulent discharge. And serous otitis media can be little different presentation, because now there's not going to be any of the infection symptom, but just the hearing loss and pressure changes, and they're going to have pain. Hemotympanum is the blood in the tympanic cavity. Okay, this is the presentation of two different types of otitis media, and these are the diagnostic tests that are again from the book. I tried to follow book so that it's easier for you when you're reading the book, right? Things are going to start to make a little more sense now when you're reading it again. These are the tests, and culture sensitivity is easy to follow, right? They are going to take fluid from the ear, and they're going to poke the tympanic membrane or the eardrum, and they're going to take little fluid from there, and they are going to send it to culture and sensitivity. You should have a good understanding of what culture sensitivity are. CBC, why do we do CBC? What are we going to check in the CBC? We talked about it in cellulitis. WBC. Okay, WBC. Pretty easy to follow, right? Thank you. And WBC. And so these three tests now, probably you're wondering what these are, right? Don't have to go in detail, should have a basic understanding. Impedance audiometry, right? In NCLEX, again, they're not going to ask you directly about these tests or directly about the microorganisms, but it can be present in the STEM. So that make sure that you know something about these tests, right? It can be there in the STEM. So impedance audiometry, what that is here, this is a picture that I have put for the impedance audiometry. This is a little device that we use for checking the compliance of the tympanic membrane. So this is the piece that gets inserted. When I am drawing on the screen, do you see my little drawing? Or I'm like teaching myself? You do? Okay, thank you. Just wanted to make sure so that I point out to the right things. So the impedance audiometry. So this is the little device that goes in the ear. It's very soft tip, as you can see the little red color thing here. And so what happens is that they reflect, they they send the sound waves and it hits the tympanic membrane. And this device on this monitor, it checks how much sound waves are reflected back to the monitor. Okay, so it checks the compliance. If there is otitis media, there is serous otitis media fluid there, the compliance will be low. Right. If it is clear, it will be reflected more. So, but just to have a basic understanding that this is the device that we use, and it checks the compliance of the it checks the compliance of the tympanic membrane. Okay, and the second is a spectral gradient acoustic reflectometry. It is also called SGAR. Okay, it is also called SGAR. So you should remember at least the name of it, that this is a test that we use for otitis media. SGAR, this is the device that we use. Okay, pretty much it's like an otoscope really, and again it sends the sound waves from here. This is the tympanic membrane, and it checks the conduction of the sound waves through the malleolus, incus, and stapes, through the middle ear. It checks the conduction, and also it checks the reflection again, the sound waves that are reflected back. But just the basic, and we don't have to get into the detail. It's really a ENT provider thing, like how to read these tests and stuff like that. Audiological testing is just again checking the conductive hearing by means of sending the waves through the bones. But these are some of the tests that we can use for otitis media. Okay, based on the tympanic membrane reflection of sounds and conducting the sounds, things like that. Pharmacological therapy in this, the main drug of choice is penicillin, and specifically amoxicillin. Okay, always you go to the doctor, especially in the kids, they will prescribe amoxicillin first. If that antibiotic doesn't work, which often at times it happens with my daughter and my son, both of them used to get a lot of ear infections, and which is pretty normal, and they tried amoxicillin, that did not work. They tried azithromycin, they even tried Augmentin, and well, finally it cleared up. If it did not clear up, then they would have gone for surgery, which I will discuss later. So these are the three antibiotics of choice. If amoxicillin does not work, they can go to cefaclor, which is cephalosporin, and azithromycin, which is macrolide antibiotic. Macrolide is a classification of an antibiotic. Okay. And other things are analgesics can be used. Again, symptomatic relief. If they have fever, you'd use antipyretics. And I just want to make sure that you recognize the terms. Okay, there was a question in in the first exam, I think, antipyretics, right? I think students had a little trouble with that. So this is for bringing the temperature down. Pyria is temperature, fever, yes. So anti-fever, okay? So make sure that these terminologies, if you're good with that, then only you'll be able to solve the questions. Analgesics are for the pain, medications for pain, right? Narcotics are medications for pain, but they have a sedative action in that. They cause sedation, right? Opioids are medication that can be used for pain, but basically something that there's a form of opium, right? And again, sedation, they have a sedative effect as well. So some of the basic classification, the names of it, just try to get used to it. There are various resources. I think there is medical dictionary. There's various apps you can download. I don't have the specific names, but I'll try to find out if we can share some of those resources so that you can, on your free time, right? You're outside, you just open the app and just go through some of the terminology so that you can get better with that. And these are, again, steroids. Usually you would think that because of the inflammation it would help, but it does not help for some reason with the ear infection. Okay, decongestant antihistamines can affect because of the allergy and the question. This is the for tested on actual bacteria. No, you will not be tested on actual bacteria. Again, for NCLEX purpose, you might see in the see that in the stem itself, right? Some of the bacteria, yeah, that is the basic knowledge on which all the other nursing concepts are built on. But you won't be asked like specifically what is this cellulitis is caused by which type of bacteria. That you will never see, because there is no, we are totally moving away from knowledge questions, both in our test and indefinitely NCLEX. So it's more of application questions. But having said that, the book readings and the PowerPoints is very important to follow. Macrolide antibiotics, again, this is the fourth type of classification that we are seeing, and there is like probably a one-page reading in your book for gram positive and gram negative. It is broad spectrum antibiotic, and mainly azithromycin you have seen, right? And very common antibiotic Z-Pak, we call it, that providers prescribe for the sore throat and for little, upper respiratory infection. So that is a type of macrolide antibiotic, okay? Clarithromycin, erythromycin, this, I've never seen, but these three are commonly used in the hospital setting. And spend consideration is a concern for drug-resistant bacteria that we already talked about, and antibiotic therapy in children more than 6 months with severe symptoms. And that's one criteria they are trying to follow now, that more than 6 months they give the antibiotics. They really wait for the otitis media to get cleared by itself if it is just the effusion, right? And if it does not, then only we prescribe the antibiotics. So minimal use of antibiotics we try to do. These are the antibiotics of choice, as we already talked about it. And quick quiz: why ear infections are more common in children? Some reasons.
Because of the anatomy of the ear canal.
There you go. Yeah, it's much flatter. What else?
Their immune systems aren't as mature.
There you go. Yeah. So you're following, right? These are the two main reasons why children are more prone to getting ear infections, right? And so this was that. And treatment. So for the serous otitis media, we already talked about it, that we are not going to use antibiotics. We are going to wait until it resolves. If there is a hearing loss or cochlear damage, cochlea is that circular structure at the end that has a cochlear nerve and vestibular nerve, and if there is a damage, really they need a cochlear implant, right? So we are going to follow with the audiologist, and if it doesn't resolve, then we move to the anti-inflammatory drugs. Sometimes that helps as well. Usually we say if like in 6 months they are getting more than 3 infections, or in 1 year they are getting more than 6 infections, that is the time that we have to now go to a ear specialist, and they have to move towards the surgery now. And the nursing interventions are give analgesics. Heat therapy can be used, and they help with the pain as well, and helps with the inflammation, elevate the head of the bed. And myringotomy or tympanocentesis. So in this, what we do is that we go from the external canal, and they place a little tube. This is a ear tube. You might have heard normally people saying that my kid had ear infection, I had to get the tubes done. So this is basically what tubes are, that in the tympanic membrane, they put this little tube so that the fluid from the middle ear can drain into the external ear, okay? And it gets out. So it stays there, and when they get mature or it gets healed, it sometimes falls out by itself. So, nothing to worry about, and mostly this happens, but sometimes they have to get the tubes done again as well. Many a times we see children getting multiple of these, but the pressure is released by means of these tubes. And so any questions from otitis media? Otherwise, we'll take 5 minutes break, and Can we see the tubes from the outside? No, you would not be able to. With the otoscope, that's a good question. With the otoscope, you will be able to see that. That has a little light and stuff like that. But it's really in the tympanic membrane. We are not able to see the eardrum from outside. That's why. Get ear infection, anatomy of the ear canal, and the immune system. Okay? And these are the two reasons why they get more infections. Sound good. Would you use heat for inflammation, vasodilation, and more? This is a question that we always get for any types of infection. So what happens is when it vasodilate, we would think it's going to increase it, but when we dilate it, there is more blood supply there. There is more transportation of the resources, of the WBC, of the good healing mechanism, and with a rich blood supply, the edema comes down. So heat therapy is recommended in this case. Sometimes, things are a little different and they might order ice therapy, not for otitis media, for some, other type of inflammations, but usually heat therapy works well just because of the blood supply. Yeah. And all right, guys. And so we'll take 5 minutes break or 4 minutes. So 10:45, we are going to be back, okay, for our next.
Professor, when we come back, can I just see slide 11 and 15 for a brief moment, please?
Yeah, slide 11.
Yes, and 15 for just one moment.
Yeah, absolutely. There. Do it now or when we come back?
Either way, it doesn't matter. I got 11. Can I have 15 if you have a sec, please?
Absolutely. So 15 is right here.
Thank you.
Oh, okay. I know why you're asking probably. So I made few changes, as I always say that, there is a few changes, minor changes here and there when I'm reading like a night before that I put in. But now this slide is uploaded in your Blackboard. Okay, so you should have the updated slides there.
Okay, thank you, Professor. Appreciate it.
No problem. You're welcome. All right, guys. All right, guys. So hope all of you are back. I know it was a quick break. It was a vast topic. We had 5 diseases that we have to cover. So we'll get started. So 2, the big ones are already done. And now we have 3, chlamydia, and then Lyme and candidiasis. So let's get started with chlamydia infection. We touched base on it last semester when we talked about STIs, sexually transmitted infections, right? And the major thing that we talked about in STIs was to to really decrease the stereotyping or completely stop the stereotyping of the STIs. When we talk about STIs, it should really be just talking like pneumonia or other ear infection or all the bacterial infections that we are talking about here, right? It's no different. So as nurses, firstly, we have to make sure that our implicit biases are gone related to the STIs, and then we have to educate others, right? It's just like any other infection, and we have to see like what treatments are present and things like that. So let's talk about what chlamydia is. So it is a STI, and the main thing is that why it can be dangerous is sometimes it can be asymptomatic and still can cause permanent reproductive system damage in women, right? It can happen in the urethra, it can happen in the vaginal area, then it gets up the vaginal canal and the cervix and the uterus, fallopian tube, ovaries, everything can get affected, right? And if there is a inflammation or bacterial invasion of all these organs, what is one term that comes to your mind? What type of infection, or what is that called?
Sepsis?
Sepsis.
Well, so yeah, maybe I was not clear in my question. Okay, sepsis is good, but these reproductive organs are now inflamed, and there is a bacterial invasion there. The reproductive systems,
Toxic shock.
specifically. What is it?
Toxic shock.
Septic shock, that would be more of systemic, right? That is like really throughout your circulatory PID. Yes, that's the word. Thank you, Samantha. All of you were at right track. That septic shock would be more of a systemic invasion of bacteria throughout your circulatory system, throughout your lymphatic system, and now the bacteria has inflamed the uterus, the fallopian tube, ovary. So PID, pelvic inflammatory disease, which we are not going to discuss now, but it's so important, and I'm sure in 3rd, 4th semester somewhere you're going to talk about PID. And but PID can happen, and permanent reproductive system damage can happen, and with little education on our part and preventive workup, this can be prevented. And it can be spread by pregnant women, can also transmit to the babies if they have chlamydia. So it is transmitted from mother to the child. Risk factor, though this is so important. What are the risk factors for chlamydia? Being sexually active, being a female, puts you at more risk. This is the age that is most at risk factor. So teenage, between 14 and 19. Chlamydia infections, usually they get like before 25 or so. Personal history already of STI, cervical ectopy. Cervical ectopy, what this is, actually I have a picture right here explaining cervical ectopy. The cells which are the epithelium of the lining of the uterus, it gets outside as well. So the same cells which are inside the uterus, they cover the cervical wall. This is cervix. They cover the cervical wall. What happens is it causes the now redness, because they are more prone to like a friction, to get inflamed if there is bacteria, and so more infection can happen if there is cervical ectopy. So it puts you more at risk for chlamydia or any type of really STIs. Multiple sexual partner, unprotected sex, drug or alcohol use. Why drug or alcohol use? It increases the chances of risky sexual behavior or unprotected sex. That also puts you at more of risk of chlamydial infection. Prevention, again, so important on our part, right? The education, the preventive measures, being in monogamous relationship with one partner, it can be a preventive measure. Using condoms the right way, in which it's supposed to be. Avoid douching. Douching can, in the bacteria can get entry into the reproductive system. So that's why it has to be avoided. Get tested. And now, what is the age? This is one question actually for all the diseases that we get confused about. Like, what is the age range when we have to, get tested for chlamydia? Younger than 25-year-old, they say, like yearly or so, they have to get tested. 25 years or older, if they have a risk factor. All the risk factors that we listed there, if it is more, so basically, if you are going to yearly regular examination, they test you for the infection. So, the one thing that we can suggest is choose a gynecologist or choose a provider, a specialist, and go for yearly examination, right? And even your yearly physical examination, they'll further guide you to follow a specialist if you are in that age range. So that's why the yearly physical examinations are so important, right? And then symptoms. So symptoms obviously are going to be a little different in female and males. And as we can imagine that there will be abnormal vaginal discharge, there will be burning when peeing, and in men, there will be discharge from penis. Again, burning, pain, and swelling in the testicles can happen, but it is less common if there's epididymitis, we call it. And but that can happen as well. Basically, discharge, pain, swelling, sometimes there can be bloody discharge as well. These are the signs of chlamydial infection. These are the complications. We already talked about this. And then epididymitis. See, this is the word I was talking about. Inflammation of the infection of the testicles, prostate infection, newborn, ectopic pregnancy that is not in the uterus, in the fallopian tube, in ovary, somewhere else. That is called ectopic pregnancy. Infertility, reactive arthritis can happen. Reactive arthritis is a type of arthritis which is caused by a bacterial infection. So really, it is saying that if there is a chlamydial infection, it can spread to other organs. I listed these complications, but any other type of organ get affected because of the bacterial invasion, again, through the circulatory system and through lymphatic system. Okay, so these can be the complication. Treatment of choice is doxycycline and azithromycin. Both sexual partners. So this is an important concept. I want all of you to remember that if a female has chlamydia or male has chlamydia, both need to get treated with the antibiotics. Okay, so you need to remember this one concept, that many a times it is thought that, okay, I'll start the antibiotic treatment, not thinking about that my partner has it too, but they both need to get treated prophylactically, even with the antibiotics. Okay, common side effects again are the same that listed here. Even if, yes, the absolutely. The prophylactically, they still need to get treated. That's the whole point. Both partners need to get treated at the same time, okay, before resuming the sexual intercourse. And that is one thing that we have to keep in mind. Even prophylactically, they need to get treated so that they don't get the infection, okay, in like next couple days or next few days. Oh, that was a very quick one. So chlamydia, there is, even in book, there is not, much information. So basically, you just need to remember the risk factors, the complications, the symptoms, and some treatment, right? On nursing part, again, any nursing intervention or nursing process, right, for any of the disorder will follow the same assessment. So in chlamydia, you can, yes, at 5. So be very I want to say get competent in using the nursing process. Lots of questions are going to get solved based on the nursing process. And now, as we are talking about it, your clue I was talking to my clinical group, your clue that you do, the first, the two concepts that it's basically the nursing process, right? It's little hodgepodge for some reason. You see it on the paper because assessment is down, the concept is up there, the evaluation, I think, is in the late. So the basic thing is if the patient has, say, constipation, right? So you are first gonna do the assessment. Everything related to constipation, a good detailed GI assessment you're going to do. Then you're going to diagnose. Your diagnose is the concept that you use. For constipation, you're going to use elimination. In bracket, you can write bowel elimination specifically, right? That's the concept you're using. And the third thing is planning. So you're going to plan. By 1 o'clock, the patient will have a bowel movement. By 2 o'clock, the patient's pain will reduce to 2 out of 10, the abdominal pain, right? This is your planning that, okay, I have to do. Now the intervention. To reach to that goal, to reach to the planning that you did to meet the goal, what interventions are you going to do? You are gonna, again, the mental format you are gonna follow, but if there is nothing, lab work, okay, for constipation, is there any lab work really that you're gonna do? So in mental, if L is now making sense, just leave it blank. Don't force yourself to write everything in every column, right? Sometimes minimum makes more sense than just filling out the whole clue, right? And so L, if it's not making sense, just leave it blank, right? For example, gas exchange or some other concept. And sometimes the nutrition, if it's not making sense, leave it blank. The one thing you need to remember, the interventions are always going to be in present sentence. Administer the medications, okay? Help patient with ambulation, collaborate with the physical therapist. You're not going to write collaborated, patient did that. No, those are not the intervention. Intervention is something that you can do, okay? Goal is something that is for the patient, that patient will do. Now, evaluation will be, my intervention was administer enema, administer fleet enema. My intervention would be, my evaluation, I'm so sorry, evaluation would be fleet enema administered, patient had a bowel movement, or patient did not have a bowel movement. Or the evaluation can be fleet enema was not administered because patient refused it. Okay, it's totally out of topic, but I just wanted to guide you a little bit on that, get very competent in following the nursing process. You might think it sometimes, I don't know why we are using, why we are using this nursing process, but this is the only way that you are going to increase your critical thinking, your clinical judgment, the terminologies that we always talk about. And all right, so this was all about this, and then we'll get to the next PowerPoint, which is again a shorter version. And so this is a really a code that is so like relevant. The most practical lesson that can be given to nurses is to teach them what to observe, how to observe, what symptoms indicate improvement, what the reverse, right? And Florence Nightingale, she was big on assessment. She was big on observation, even 200 years ago. And I did not put in here, but there is a strong quote that followed this quote in the same book. She writes, if you cannot observe, nursing is not your calling. It's strong words, right? And it was difficult to even read when I saw this, but it is so right. If you cannot observe, nursing is not your calling, right? This is your main part, that you see the patient, that patient is either deteriorating, you assess that patient is in cardiac arrest, or the patient will go in cardiac arrest in next 5 minutes if you don't do anything. That is being a competent nurse, okay? That you are able to call the provider, you are able to call the multi-specialist nurse, you're able to initiate the CPR, whatever you need to do. But if you are not able to observe, if you're not able to assess, that is a problem, okay? And so really, like in your clinical rotation, now you have clinical tomorrow, day after tomorrow, I would strongly suggest work on your assessment skills, head to toe assessment, focused assessment, right? I always say that patients assessments are like our babies, like moms know each and everything that's on baby's body, right? We even know, like, mentally, but, but physically, we know head to toe that this is a birthmark that my baby has. My baby has like these type of nails, they have long hands, and, the hair looks like that. So really, we have to be that detailed in our assessment skills. Okay, so tomorrow, after tomorrow, please, like, I know you already are working and you're doing a great job, and really I'm so proud of all of you. Like, I see, at least I can talk about my clinical group, that we see the efforts that you guys take, all day. Like, I have special 12-hour clinical, so all day I know students are in and out of the room and they are trying to make sense in the computer. So but again, work on the assessment skills. That's one point that I wanted to stress. So this is all about that. And any questions from this PowerPoint? Otherwise, we'll move to the next one. All right, and so now we will talk about the rest two of the diseases that are left, is the Lyme disease and candidiasis. Lyme, I'm sure you have little understanding about that. Ticks, deer, these are the words that come to our mind. But little more understanding is that it is a vector-borne disease, that it needs a vector to survive, right? The bacteria, or the spirochete type of bacteria, Borrelia burgdorferi. This is the name of the bacteria that causes Lyme disease, Borrelia burgdorferi. And so it needs oh my God, yeah, I know, yeah. So at least you found one and you took it out, and hopefully it was not like the initiation of infection or something. So we'll talk about it as Ryan engorged. Okay, so perfect. And so we will talk about it, how to check the body and how to prevent Lyme disease. And mainly it's prevention. For Lyme disease, really, when we get to the cure part, it's already infected, it gets a bit difficult. So prevention is a big thing in Lyme disease. So what happens is it is spread by the ticks, as you already know. Borrelia burgdorferi, this needs a warm-blooded animals to survive, to grow, to become an adult. Okay, and so the cycle, the incubation is 3 to 30 days. Within 36 hours or so, then we will start seeing the symptoms, but it can be as long as 30 days. A typical symptom, the rash that is formed, which you can see here, it's not like very clear, but this is a bullseye rash. The other name is erythema migrans. This starts to happen after the invasion, biting of the tick. So it literally, pokes its head into the skin, and that's how it transfers the. But sorry, is everybody having problem hearing me? Are you able to? Okay, yeah, probably it was 1 second or so that it happened. Okay, and thank you. And so what happens is, let me know if you still have issues and with hearing. So it pokes the skin, and this tick, it transfers the Borrelia into the skin. Okay, and again, we're talking again and again about lymph and blood, right? So that you have a good idea of how from one point infection goes to the whole body, lymph and blood, lymphatic system and circulatory system. And this is the cycle of infection, guys. So that you have to understand, in spring there is eggs of the ticks. Okay, so they become larvae, as you know, eggs and larvae and adults. So they become larvae, and this larva, it goes into a warm-blooded animals, and basically they choose mice for their reservoir. This is a reservoir. So they choose mice and they grow in it, and they become into a nymph. Nymph is the third stage of growth of the ticks. Now it's infected with Borrelia, and so now it becomes a nymph. And most of the infections with the Lyme infection, it is caused by nymph or the adult. Okay, larval stage or the eggs definitely is not going to cause any infection. So when it gets to the nymph stage, then it finds a host and the host is usually the deer, as you all know. And so it attaches to the deer, it feeds on the deer blood, and then when we are outside, it's get transferred to our body. So they bite the human skin, and that's how they get there. And because of their developmental stage, we are at most risk for infection in late spring and in summer. But again, as Ryan shared, that any season it can happen. Outdoor activities in the wooded area, in the bushes, for example. We had a lot of like bushes and stuff like in the backyard, like at the end of the boundary of the backyard. And so we got the whole thing cleaned. It was probably like for 5 years or so we hadn't cleaned it. So we got everything cleaned, but the ticks that were there, they literally got out of control in our backyard. I'm not even kidding. So because we got it cleaned, now they got spread into the backyard. So you can imagine we had to call for putting the sprays and stuff, which I will talk about, what type of sprays are best for that. But this is a cycle of the tick, or how they infect us. Signs and symptoms, early and the late symptoms. So early symptoms are pretty simple, that you will see that tick bites the skin. There will be bull's rash, erythema migrans, and it will cause some fever and fatigue, malaise, joint pain, swollen lymph nodes, skin lesions, and just like little spread here and there it's causing, right? Lymph nodes basically have all the fighting mechanisms, our soldiers that we talked about. So it has our soldiers of macrophages, dendritic cells. So when there is an infection, lymph nodes go crazy, like they have no idea what is going on. So they start to produce more macrophages, more dendritic cells. That's why they get swollen. So when they are swollen, that's one sign that there is some infection going on in the body. In the later stages, it's pretty serious infection, serious symptoms that can start to happen. On next slide, I have a little mnemonic that you can remember. These are 4 symptoms are the major late stage symptoms that we know. Bake a key lime pie. So lime pie, I'm sure you have, maybe tasted it or baked it. So lime pie. So you can remember bake a key lime pie, and it is BAKE. Bell's palsy, it is the damage of the 7th cranial nerve, which is facial nerve. Arthritis can happen. Cardiac, it really starts with C, but just for the mnemonic purposes, it is cardiac block, or I can say arrhythmias will start to happen, and erythema migrans that we talked about. So these are 4 classic symptoms, I want to say, of Lyme disease. You can remember with this little mnemonic that is presented here. Prevention. So here is the main thing. How do we prevent Lyme disease? This little picture gives you an idea. After playing outdoor, we have to inspect the kids' skin or our skin very thoroughly, right? Not just checking here and there, like on the hands or something. So these are the spots where the ticks can hide, under the arms, right? Groin area, belly button, legs, and here. And the ticks, they release an enzyme which basically numbs the area where they attaches, right? They're so smart, and not like mosquitoes. When mosquitoes bite, we know, the pain, and we know that's there. But for the tick, it numbs the area, so we would not know when they are on the body. So that is the whole problem. And so this is the little solution, 0.5% permethrin, which can be used for washing the clothing and gear after outdoor activities, especially like gardening or hiking and stuff like that. And use environmental EPA registered insect repellents. If you just put this on Google, and there will be authentic site that will talk all about it. But basically, this is a chemical that must be present, DEET, as an insect repellent. It can be used on the kids very safely. It is FDA approved. Basically, what it does is it repels the ticks. It repels the insects, other insects as well. They just don't like the smell of it. Oh, no, I'm so sorry. This is not the mechanism. They cannot smell human body. When we put the insect repellents containing DEET or even other insect repellent, they cannot smell the human body. So we are basically not present for that. They can find us. That's how we get protected with these repellents. So avoid wooded area after coming outside, shower, check the body. This is really so important, which is one practice that I'm always following. Right, which I'm always following with my kids whenever, because they love to play outside like all other kids in the grass. And again, it's a great experience, right, to play in the grass and stuff. We cannot we can do is when they come back, we just have to make sure, because it's the invasion, what they call it, incubation cycle is at least 3 days, 36 days, right? So if we check their body right away, very nicely, we give them shower, we wash their clothing, they are pretty safe, right, from any Lyme disease or tick-borne infection. These are very simple, like it's a picture that I put there, prevention of ticks in backyard. So you make sure that these are the problem areas that have that is there, that avoid going there, or use the insect repellents and get these cleaned timely, so that it's we are less at risk. Treatment. So the treatment of choice is doxycycline here, and it is a tetracycline type of antibiotic, okay, doxycycline. And we usually give 30 days course of doxycycline for Lyme disease. And so the adverse effects of tetracycline, which is so important, doxycycline, that it can cause kidney damage, it can cause discoloration of the teeth. And diarrhea can happen, and it can cause liver damage. So I just want to stress maybe on the next point I had. So the tetracycline, doxycycline, such a good antibiotic. It starts to work right away, and there's not so much resistance that we have seen so far. Very good antibiotic, but the problem is that it causes chelation. Chelation, you might have heard about the term in microbiology class, that it starts to make chelates or it reacts with the calcium, it reacts with the iron, it reacts with the metals, this antibiotic, and it starts to form chelates. And that is the reason that when we take doxycycline, some of the doxycycline, it starts to react with the calcium in the teeth. Similarly, it's going to start very uncomfortable, absolutely. And so it starts to, hit on the bones as well, wherever there is calcium or iron. So that's one reason why we need to make sure that the absorption is decreased if patient is taking any of these things. Okay, so we have to make sure if they are taking antacid, they take at a different time if they really have to. They should stop the iron supplements. They should stop the calcium supplements, magnesium, all the metallic things that they are taking. So I have even put a picture here that you need to make sure that if a patient is saying that I will take doxycycline with milk because that's how I take all of the medication. No, that is a big no. It's a problem, right? It's going to start to make chelates, which is really not going to do it. The antibiotic is going to get ineffective completely, okay? And so you have to make sure that we educate patients on that, and no calcium supplements, or they're not going to take any milk or milk products with them. And other antibiotics can be used, amoxicillin, ceftriaxone, cephalosporins, penicillin. Again, we are revolving in all these infections, we are revolving around these 4 categories of antibiotics, which I already have mentioned. And questions from Lyme disease. I know it was like probably half a page reading in your book, so not too much detail. The basic is that doxycycline will be used, which is a tetracycline, cannot be taken with any metallic supplements or calcium supplements, milk or milk products. Main thing is preventive measures that I listed very nicely on 2 of the slides, okay? And there was a little information about the cycle of the tick-borne infection, how that happens. Any questions, guys, from this? Is it dangerous to leave the head in? Yes, we have to take. So how we do that is a very good question. Prevent chelates. Yeah, first let me take the question on the head. So how we do that is it literally pokes the skin with its head, okay? So the best thing to remove the tick is to take what you call it, tongs, the tongs. Okay, you can help me with that. What is the name of the thing that we use?
Tweezers.
Plucker, tweezers. Okay. Yes, thank you. Sometimes I struggle with the words. Tweezers. So you take tweezer and make sure that you hold the tick from the head. Why? There is Borrelia burgdorferi in the belly of the ticks or in the body of the ticks, okay? If you squeeze the tick from the back of it, there are chances that it's going to shoot some of the Borrelia, some of the spirochete bacteria that we just talked about into the body, okay? So the best thing is that you literally hold the head of the tick and just pluck it out with the tweezer, okay? So that was a good question, and I
Yeah,
wanted
the
to
same thing
touch base on
happens
that.
if you burn it with a match. People say to burn it with a match, but don't do that because it'll make it regurgitate into your body. And so the tweezer, you have to do it with the tweezers.
With the tweezer. Thank you for sharing that information. And yeah, so the best thing is just take the tweezer from the head, take it out. Okay, then you can follow up with your doctor, and if you want to, and say, but the intubation is really like from 3 to 30 days. And chelates, I think they had students had question how to spell it. It's CHELATES, and again, we don't have to go into the detail. It's really a microbiology class, and heating up tweezer, that also is a bad idea. Yeah, that is a bad idea. So we have to make sure that we are not, putting the bacteria into the body when we are taking it out. So this is the only best practice to take it out. Ziploc, yeah, absolutely. It does not sound bad. Again, we have to choose between ticks and human beings. So, anything that works to kill them, we have to do that. So it is not bad at all. And chelates is this. So chelation process is that when there is a kind of reaction or interminglation of the antibiotics with the metallic elements, they make chelates, and then it becomes ineffective. Okay. That is the basic process. Again, we don't have to go into detail of chelation or chelates, really. And yeah, the main thing is that the teeth will get discolored, and it will be ineffective. Yeah, so that's a good information as well, that you send it to the organization, as Heidi put in chats. They will test for the Lyme. That's what I did for one time as well, that we started finding these little things, but it was not tick. Sometimes we think it's tick. Tick is really 8 legs. That's the one thing that we can see when in the larval stage 6, but in adult or nymph stage, it has 8 legs. That is little distinguishing factor for the ticks. Okay, and so our next and last is candidiasis. Candidiasis is a fungal infection. We did talk about it a little bit, I think, last semester. So candidiasis of mouth, throat, and esophagus. So you might have heard of the word thrush. Thrush is a candidiasis of mouth. You can remember in that way. Thrush is a fungal infection. So is candidiasis. It is the same thing in the mouth. This is how it looks in the mouth, right? And the one medication that we give is nystatin, that you have seen probably a lot of time. So it is swish and swallow medication. So you swish it, you swallow it. If they can't swallow it, they can spit it out. Basically, the thing is that we let them swallow it, so that even if there is any infection in back of the throat, in the esophagus, that gets cleared as well. So it is a swish and swallow for nystatin. And this is in the mouth, in the throat, and this is the esophagus, guys. So esophagus, that by naked eyes, we cannot see if the esophagus is infected. We have to send patient for endoscopy or something, then only we will be able to proceed with the treatment. But basically, this nystatin, it works on the mouth, throat, and esophagus. And the terms that we use is candida esophagitis, and then oropharyngeal candidiasis. In the stomach, it is not in the throat, oropharyngeal, in the mouth, mouth and the pharynx. So these are some of the terminologies. The symptoms will be white patches. Now you are very familiar with that. White patches, fungal infection. In the kids, you can see that, especially with the bottle feeding with the milk, it gets difficult to clean their mouth. So you see that they get this redness and sore cotton-like feeling, loss of taste, pain, cracking, redness. So these are very general symptoms of candidiasis in the mouth or in the oropharynx. Risk factors are when you have dentures. It's a good picture that has list 2 risk factors at least, having dentures and smoking. These are 2 risk factors along with diabetes, cancer, HIV. Cause of the immune response, your immunity will be less and they will be more at risk. One risk factor that I want to cannot stress this enough, and you must remember that if patient is on steroids, that also puts them more at risk for fungal infection. Okay, so why? Because it lowers the immunity, it messes up your immune system. Now the immune system is not able to prevent this candidiasis that is happening. So why this is so important to remember is often a time patients with respiratory issues, COPD, they will have a steroid inhaler. Okay, they will have a steroid inhaler that they use, like albuterol, right? Yes, rinse and it, or yes, absolutely. Thank you. That's what I was going to say. So after using the steroid inhaler, you must give them a cup of water and a kidney tray or basin or something. They need to rinse their mouth very nicely. This is one thing that we always have to make sure and not forget. This simple 2-minute thing can prevent a bad oral fungal infection. Okay, so always remember, patients who are on corticosteroids, inhalers, they are going to be at more risk for thrush, fluticasone, albuterol, and the mixture inhalers, right? All of those are steroid inhaler, because basically that's how it works, right? There's a bronchodilators, or those are steroids that reduce the swelling in the windpipe and the trachea, and that helps with the breathing. So always make sure that you, if you give inhaler to your patient in your clinical rotation as well, you must give them a cup of water and let them rinse the mouth very nicely. Sometimes this part is missed and then they end up with a bad infection and dry mouth and stuff. So these are the risk factors. Diagnosis of pertaining to inhaled, yes, it is only for inhaled corticosteroids. The systemic or oral corticosteroid, that in general puts you at more risk for any type of infection, because it lowers immunity. But basically the inhaled specifically messes up your mouth flora and stuff like that. And so the rinsing of the mouth is just for the inhaled corticosteroids. So diagnosis of candidiasis. So basically, when you look at it, you will know this is a thrush. It's that simple. It's going to cause like white patches there. Rarely microscopic evaluation, endoscopy for the esophageal candidiasis can be done as well. Systemic invasive candidiasis. As I said, that maybe thrush is easy to treat. Nystatin can be given, some oral antifungal can be given, but if it invades now your circulatory system, which I once took care of a patient who had a bad fungal infection in the bloodstream, and the patient was getting fluconazole intravenous, amphotericin B, those are all antifungal medications, but really in bad shape, that vitals were all messed up, lab work were all messed up. That's why it's so important to take care of the infection when it starts. But invasive candidiasis, as you can imagine, is a serious blood infection that can go to any organ really, and it says heart, brain, eye, bone, or any other part of the body. Fever, chills. Now hopefully you are really good in a presentation of patient with the systemic infection. Quick quiz is, which item would you tell the client to stop eating if they are taking tetracyclines? Oh, this is going back to the tetracycline, doxycycline from the Lyme disease. Cheese, yogurt, spinach, iron supplement, magnesium containing laxatives, all of them. There you go, all of them. Why I put all of them is also to stress the point that whenever we give you any select all that apply, do not think that it's either 3 or 4 out of 5, right? It can be all 5 as well. That's one thing that we have seen with the select all that apply, that you tend to choose 3, right? It can be 1 as well, right? It can be 5 as well. So, but here in this case, I just wanted to make sure that you understand the concept that any calcium containing food, any iron containing food, iron supplement, magnesium, any metallic supplements are to be avoided. Risk factors for systemic candidiasis: patients who are in the ICU, who have a central venous catheter, anything that can invade the that is invasive device can put you at risk. Lower immune system, patients with cancer, had surgery, a lot of antibiotic. This is one thing to remember. Patients who are taking a lot of antibiotics, again, disrupts the normal flora, kills the good bacteria in your body, and you are going to be at more chances of fungal infection. One time I had a patient who had a hip surgery. I'm so sorry. Hip surgery, and patient was getting a lot of antibiotics because one was not working, patient was resistant, again had infection, and a patient got a really bad fungal infection at the site of the surgery, and literally like where the surgical scar was, that whole thing had fungal infection. Why? A lot of antibiotics messed up the normal system protective mechanism of the NETP, kidney failure, diabetes, preterm, same concept. Vaginal candidiasis is the candidal infection, fungal infection at the vaginal area, which is very common. And these are the symptoms that you might have with the vaginal candidiasis. These are the risk factors, pretty self-explanatory, that are listed here. Patients who are, in the pregnancy, again, this is all because of the normal physiology of the body is disrupting with the contraceptive pills, a patient having diabetes, weak immune system, antibiotics. So they are more risk for vaginal candidiasis. The fungal treatment that will be used is the nystatin that I told you for superficial infection. For that, this is the really the bottle of nystatin. This is a little cup that we use. We pour the 10 ml to 15 ml of nystatin, give to the patient. They swish and they swallow, swish it nicely. And these are the adverse effects that is listed. And so for oral candidiasis, it says for children and infants, they won't be able to swish and swallow. So if they can, it's fine. Otherwise, we can put it with the swab. Even in the patients who are on ventilator, unconscious, we can take a swab and put some of the nystatin in the mouth, okay? And keep it for 2 minutes there. Azoles, so the nystatin, and for systemic infections, we use azole. It is in chapter 36. There is a couple pages of azoles and antifungal antibiotics. For example, fluconazole, miconazole, ketoconazole. Sometimes it is a lot of dandruff in the dry scalp, dandruff in the head. Ketoconazole is a medication that's available over the counter. You wash your hair with that, clears it in one shampoo. And primary uses for these systemic infections we treated. As I told you, my patient was on this fluconazole intravenous. It was in a little piggy bag instead of IV push. It is a piggy bag that we give. Sometimes intramuscular formations are also available. Candida albicans is the main thing, main organism that is there. And these are some of the adverse effects that are listed. Again, any antibiotic, any antifungal will be bad for your GI system, will cause all those adverse effects. Nursing implication is to finish all the medication, more fluids, avoid alcohol, report any symptoms, cleanliness of the hair and everything to limit the spread, general cleanliness, right? And so that it does not go into the other parts of the body. And this is one last code. So deep rooted or universal is the conviction that to give medicine is to do something, or rather everything, right? So what it's saying is that we think that nurses' part to give medication is everything. It's not. To give clean air, warmth, cleanliness is to do nothing. The very elements of nursing are little understood, right? So really now we are not going into the clinical rotation or as RNs where we are the unit. We are not there just to follow the provider order and to give the medication. No, that is one part, really a one part of nursing, right? To assess and general cleanliness, right? And taking care of the environment. So that is the holistic care, the wholesome care of a human being. So these are the elements of nursing that are very little understood, she says, okay? All right, guys. So this sums up our 4 disorders, and we were able to finish it in 2 hours. It was a very vast topic, I know. Do you guys have any questions? So I open the session. I know we are at time, but I am here, and so if you have any questions, please, you can ask me. And again, I am available via email, via, messages. I'm available for Zoom meetings. So never hesitate to reach out to me if you need anything. But if you have questions, I'm here.
Professor, how does the
Yes.
TPN make you at risk for thrush?
Oh, that's a very good question. So with the TPN, what happens is it puts you, first of all, that it puts you more at risk for diarrhea, right? The elements that are there in the TPN, those are not a complete nutrition for which your system is working to digest the body, right? So that also disrupts the normal immune system, right? That's one thing that TPN does. And the second thing is it is always given through the central line, and it is always given through the PICC line. So anytime when there is invasive lining in your body, that itself puts you more at risk for the infection. So that's how TPN puts you more at risk for infections, and also more at risk for diarrhea and stuff like that.
Thank you.
You're welcome. What? Any other questions, guys?